Thank you so much, Dr. Chandramohan, and I'm glad some people are still there in the hall. That speaks volumes about the way this meeting has been. The topic given to me actually was immunotherapy in colorectal cancer. So I've taken the liberty of modifying it to localized colorectal cancer, because this is a meeting of surgeons, so I don't want to bore you with all the Kaplan-Meier curves that medical oncologists typically show. The second is that I'm going to leave you with more questions than answers. At the end of my talk, I'm happy to have your views on whatever I'm going to say in the next 10, 12 minutes. We'll start with some basic caveats. The data that I'm going to discuss about today is purely on immune checkpoint inhibitors in MMR deficient or MSI high tumors. Now, you can do the test by immunohistochemistry, which is the simplest, easiest one that we do routinely in practice. You can do PCR, or you can do a next-generation sequencing. We are moving to next-generation sequencing more often. The percentages shown there are MMR deficient tumors in colon and rectal cancers, which can vary depending upon the stage. The prognosis of these tumors also vary depending upon the stage. If you've got somebody with a stage 2 MMR deficient cancer, that tumor is going to really do very well, super good biology. If it's going to be somebody with the same MMR deficient tumor, but it is stage 4, that is associated with terrible biology. Stage 3 is something very equivocal. Some patients do well, some patients don't. We will not get into that intricacy. But for me, the most important thing that can modify all of these things is the exquisite sensitivity of these tumors to immune checkpoint inhibitors. So its prognosis will vary depending upon the stage, but the predictive value in terms of sensitivity to immune checkpoint inhibitors is irrespective of stage. Now, this is Foxtrot. We've discussed this in the afternoon, but the point I'm making here with this slide is that chemotherapy works very poorly in MMR deficient tumors. This is Foxtrot. This is patients who had neoadjuvant therapy, and what you're seeing on top there is TRG 0 to 4. That means patients who had no regression to patients who had super regression. What you see here is that the red block is the MMR deficient tumor, the blue block is MMR proficient. In most patients, you actually don't see any regression at all. That is not PCR 7, that is 7% of patients who had a major regression compared to 28% of patients with proficient MMR who had good regression with chemotherapy. You also see there in this Kaplan-Meier projection there on the left side, this is for proficient MMR patients. That's where the difference in terms of DFS is there, that 5%, 6% difference that you got in Foxtrot. If you did neoadjuvant for patients with deficient MMR, there's absolutely no difference. So chemotherapy works, but chemotherapy works terribly poorly, and that's probably not the best thing to do for our patients with MMR deficient tumors. A very busy table. These are all the studies done so far in localized colon and rectal cancer with immune checkpoint inhibitors. Again, some basic caveats. Treatments varied between 4 weeks to 24 weeks. Nearly 100% of all patients complete their planned treatment. There's no increase in perioperative complications with the use of immune checkpoint inhibitors. But the most interesting, imposing data that you're seeing here is the responses that you're getting in these tumors to immune checkpoint inhibitors. You see that there's a pathological complete response that ranges anywhere between 60% to 100%. Now try to recollect the last time you've heard a figure like this, 100% pathological complete responses. It can't get better than this. Of course, the varied set of tumors, both colon, rectum, T3, T4, N+, and then you have patients who had Lynch syndrome versus not. Lynch syndrome patients respond better to immune checkpoint inhibitors compared to non-Lynch syndrome MMR deficient. So those are some molecular intricacies. So for me, this data is too good to be true, but it is actually true. Again, Wesley showed this in his presentation on neoadjuvant therapy. This waterfall plot is now being called the Chalabi plot. Mariam Chalabi is the principal investigator of this study that's called as the Niche 2 study. What did they do in the Niche 2 study? They took patients with MMR deficient colon cancers, and then the primary, and then they randomized, sorry, this was not a randomized study. So they put these patients on just 2 doses of nivolumab and 1 dose of ipilimumab. Don't worry about the names. The point is that dual immune checkpoint inhibitor was used in this study. The primary endpoint was not efficacy, it was a safety endpoint. The point was that you should get to surgery within 6 weeks of enrollment, and there cannot be a more than 2-week delay in patients getting to surgery. So that's the primary endpoint. Again, very unconventional. You would always hear PFS, OS, and so on and so forth. That is not the endpoint of the study. Of course, a co-primary endpoint was the 3-year progression-free survival. Primarily, what they were trying to look at is, are patients able to get to surgery on time? Because that's the most important treatment for patients with localized colon cancer. 66% T4, 67% N+. And as was pointed out earlier during the day, you cannot get a better waterfall plot, right? Everybody responds. There's not a single patient in whom there's no response at all. Again, very unusual. 69% of all patients get a pathological complete response. Okay? This is a forest plot that's not showing you difference because this is not a randomized study. What you're seeing there is, are there some markers which tell you that your probability of a PCR is high? 69% PCR, that's what you're getting in this study. 98% of patients ended up at surgery within the 2 weeks. That's the stipulated time. More importantly, the follow-up now is for 2 years. 36 patients have crossed the 2-year mark. None of them have relapsed disease. Okay, none of them have relapsed. Of course, all of them have had surgery. But the point is that 2 to 3 year disease-free survival is a clear correlation with overall survival in patients with colon cancer. So if you've got a significant number of patients who have reached 2 years, they've had surgery, but they haven't progressed, now this is really something that you need to watch out for. But the question that we are asking today is it ready for prime time? I think that's the most important question. All of these are surrogate endpoints. We don't have overall survival data on any of those studies that I showed you in that table, that busy table 2 slides ago. So the question is, we have to ask ourselves and ask our patients, are we satisfied with the endpoints that we are seeing now in order to start using this in all patients with localized colorectal cancers who are MMR deficient? I'll show you some guidelines in a moment. But for people who are really evidence-based, they would want a randomized controlled trial to answer this question. In my opinion, and in the opinion of most people, this is unethical to do. You can't have a treatment that's giving you a 67% pathological complete response to nearly 0% pathological complete response and say, I'm going to put you on a treatment that I already know is hardly effective versus another treatment that is super effective, and then I want to ask you to get randomized to one of these. I would not be ready to take up a trial that is going to randomize patients, immune checkpoint inhibitor versus an alternative treatment, which is typically going to be chemo. I think the question should be, is chemo going to add to the effectiveness of immune checkpoint inhibitor, not whether the immune checkpoint inhibitor is useful or not. This is the 2024 NCCN guideline. So the one on top is colon cancer. Based on the Foxtrot, and again, as was shown in the afternoon, patients with T4, especially those who are needing multivisceral resections, are candidates for neoadjuvant therapy. Consider not that everybody should go on neoadjuvant therapy. But when you come down to the rectal cancer guidelines, it's much broader because we've got longer follow-up on patients with rectal cancer. So anybody with rectal cancer, the locally advanced disease as we would label it as, who can't go in for upfront surgery or who should not be operated upfront and have an MMR deficient tumor, are candidates for an immune checkpoint inhibitor, not chemoradiation therapy followed by surgery. It probably should be immune checkpoint inhibitor and then surgery after that. What is the incremental benefit of chemo? What's the incremental benefit of radiation therapy? We still don't know. We've heard Dr. Gina Brown speak about this afternoon. Where is the problem then? The problem is here. If you want to do immune checkpoint inhibitor for all MMR deficient patients based on radiology, you are going to overtreat nearly 50% of all of these patients who probably needed surgery only. Because if Wesley showed you data to say that overestimation happens in 25%. Nodal overestimation happens in 50%, nearly 50%. That's what that block on the right side is showing you. Nearly 50% of all patients who actually don't have pathologically involved nodes, if assessed based on radiology, would be misclassified as node-positive disease. Now, this will be higher in patients with MMR deficient tumors because they've got a lot of lymphocytic infiltrate. Remember, Dr. Brown also spoke to you about the prognostic importance of lymph nodes. She said, if you're seeing more lymph nodes, prognosis might actually be good because these patients are mounting an immune response against the tumor. So you will see bulky lymph nodes. You will also see bulky disease in these patients. Somebody was talking about obstruction. They ended up with obstruction when they treated with an immune checkpoint inhibitor. There's actually role for prophylactic colostomy in these patients who are coming in with impending obstruction or have bulky tumors. Having obstruction on immune checkpoint inhibitors has been clearly reported, and there's a small percentage of patients who end up in the operating table even before they complete their immune checkpoint inhibitor course because they respond, but they have increase in size. The other important challenge you will always face is the radiology pathology mismatch, even in terms of assessing response. Now, in the niche 2 study, I put there at the bottom, of the 75 patients, there were 110 patients, 75 patients had pathological complete response, only two of these actually had a radiological complete response. So your radiological assessment goes out of the window. If you did your immune checkpoint inhibitor, you decided to operate, you jump in. There's no point in doing a radiology to see whether they respond. How many patients progressed? None progressed. So there's no point in restaging these patients to see whether they've disseminated during the course of your treatment or not. So, food for thought. But then the question is, this is not standard. We've got surrogate endpoints. We are still very early during the course of this. So, why is neoadjuvant attractive here? We said very clearly in the afternoon that neoadjuvant chemotherapy is not standard for colorectal cancer, except in, I would say, colon cancer, except in very selective situations. But why is it very attractive when it comes to MMR deficient tumors? Because all the data is for the neoadjuvant setting. There's no mature data for the adjuvant setting. We all know from studies in melanoma that immune checkpoint inhibitor works better when your tumor is in situ. There's data, if you do immune checkpoint inhibitor pre versus post-surgery in patients with melanoma, it works better pre. There's improvement in DFS. This is probably the only situation in the body where we have clearly shown that doing the treatment pre-surgery is better than doing it post-surgery. It's a short course of treatment. We said 4 weeks to about 24 weeks at the maximum. That's what we do in rectal cancer. But if you wanted to end up doing adjuvant chemotherapy, how long would you do? We just don't know for that. The most important dilemma is if you operate and you send it to me, I find that it is MMR deficient. Am I really justified in doing chemotherapy for that patient because he or she is node positive, fully well knowing that this treatment does not work? Because the guideline today would state that if it's node positive, let's say T3N1P, T3N1, I have to do chemo. I don't have data to do immune checkpoint inhibitor. That's what I should actually be doing. But because of lack of data, I'm going to do chemo. And we showed you data to say that chemotherapy works very poorly. But that's unfortunately the standard of care. And then the problem, as they say, the elephant in the room is how good is your testing, right? Now, the other thing Chandramohan sir was asking so many times today, are you going to give us job in the future? Are you going to take us away? Yes, there's a good possibility that this is a setting where you might actually lose your job. So you may want to migrate to some other anatomical subsite. Don't be an MMR deficient surgeon, right? So that's why you should. So how important this is in colon cancer, it may not be as relevant as in rectal cancer, because colon cancer surgery today comes with very little morbidity, but there are always patients who may not want it. And then are all PCRs the same? We know from breast cancer that if you start with a big tumor and you get a PCR, you still have a higher likelihood of getting the disease back compared to somebody who started with a smaller tumor and ended up having a PCR. So the quality of that might also matter. So that's the last slide. So this is where we are probably getting to, right? If you have a deficient MMR or an MSI high tumor, if you've got CT4, EMVI, we are hearing this more often in colonic tumors now, not in rectal tumors. EMVI, then you probably will straight away go up to neoadjuvant immune therapy for all the other surgery, but that's very provocative. It's very intuitive to say that even the others should probably go into this category, but for the fact that our radiology is so terrible at this point in picking up those lymph nodes as to whether they are pathologically involved or not. So for fear of over-treatment in nearly half of all patients, we are sticking to the beaten track, which is probably not the ideal track. Should you do a laparoscopy, do a biopsy of the lymph node, and then decide whether you want to do immune checkpoint inhibitor? I'm actually thinking about it as I'm talking. Some better way of assessing that lymph node before you close, get out, immune checkpoint inhibitor, don't get back to the OT at all. Thanks so much.
Thank you, sir. I think we are happy that only 15 to 20% are MMR revision. That we'll
do a better test to pick up more.
Still some job.
Still, we can treat 80%.
Any comments?
Because I think that seems to be the
I think we have to move fast. We have 4 sessions, 4 topics to complete.
Sir.
Sorry.
No, please.
Faiz is here as well. So actually,
I was loud enough to keep people awake.
Okay. So primary it works well. Okay, metastatic disease works well. What about peritoneal metastasis for immunotherapy? See, it's not very consistent. So we can get away with cytoreduction and HIPEC. So with immunotherapy, there is 21% progression for peritoneal disease with immunotherapy, 50% stable disease and 20% complete response. We have patients who come with MSI high, resectable peritoneal disease, and now there is a conflict where someone wants to give immunotherapy for a patient where you think the survival is 42 months versus doing the standard of care and immunotherapy. So what would you do?
So I think we should never forget one important thing, that standard of care remains standard of care until something else replaces that standard of care. So the answer to your question is, the data that you're quoting is with just single immunotherapy, where you see that during the first 2 months, about 30% of patients will drop down off that Kaplan-Meier, and then it kind of stabilizes afterwards. If you see the more recent studies with dual immune checkpoint inhibitor, that is a straight line. So I think the answer to your question will be, we should start moving to dual immune checkpoint inhibitor. There are no randomized trials between 1 versus 2, but the answer to your question will be, if you have somebody who you think has got bad disease, large volume disease, dual will be better than 1.
And the other thing you got to also look at it, the cost of thing. You see, it is very good to give someone hope. Okay, you can be cured, and then you see the cost of therapy is 70,000. You need 2 years of therapy. Okay, so you have to be.
Absolutely agreed.
I think in all your presentation, you're a very good man, but you have to show the other side as well.
I think the other side is the cost, without any doubt, but I think it's getting cheaper and cheaper. So when it was let's say 3, 4, 5 years ago, when we got immune checkpoint inhibitor, the cost of a year's therapy was 35 lakhs, only 35 lakhs, right? Now it's come down to 10 lakhs. I think with the biosimilars coming in, it'll go down further. So it's just like every other thing that has evolved in oncology. It started with a humongous cost, obscene cost, and then now it's available. ctDNA tomorrow will be available for 1,000 rupees, I'm sure, in 5 years' time. So we won't have this discussion at all.
I don't think we'll have a meeting like this if that
Exactly. I won't have a good room as good as what I have, Boban.
Just to make a comment, we treat peritoneal mesothelioma as well. And you were talking about combined Ipi
and Nivo.
Ipi and Nivo.
Yes.
We've seen remarkable responses to peritoneal mesothelioma. So,
correct.
So that's first-line treatment in the UK.
I think if you have bad disease, dual. If you've got not so bad disease, I think there's nothing like good disease. I would suppose single is good enough.
Thank you, Senthil. We love to talk for a long time,
Thank you.
hear you
Thank
long
you.
time, but it is.
I don't.
Thank you.